It's my pleasure to introduce Dr. Samei Huda. He is a consultant psychiatrist working in the NHS in Manchester. In addition to adult psychiatric patients, much of his clinical work is devoted to the early intervention in psychosis service. He's from Scotland, but has lived in England for half of his life and has also spent about a year working as a psychiatrist in Australia. And he's the author of the brilliant book, The Medical Model in Mental Health, an Explanation and Evaluation. And I'll put a link to that book in the comments section. So I'll just double check that we're recording, which we are, and over to you, Dr. Huda.
All right, thanks. So I was in my book, and someone said the colour is an Iron Brew colours. Got my Iron Brew sponsorship there. I actually do have shares in bars, the company that makes Iron Brew. So I don't think I have to do this now, do I? So I'll try and speak not my baseline speed. So I mean, this bit is a bit of so I started doing a lot of the background reading for this book in obviously the shadow of the independence referendum. And then I started to actually write the book as the Brexit referendum happened. And in a way that was the sort of, the metaphor of my book was, is medicine part of the continent? Is psychiatry part of the continent of medicine? Is it like in the center of medicine, like general medicine? Is it on the periphery of medicine, like Italy or Norway? Or is it like United Kingdom, which at the time was politically part of Europe, but is separated geographically from the rest of Europe by the sea? So is psychiatry sort of detached from the continent of medicine? And I suppose the similar sort of concept was going on in the independence referendum. And I think similar sort of issues arise is that what seem like plain facts, even plain mathematical facts, are ignored because people's values, if they don't like what the facts say, their values sort of get in the way and they turn the facts into something else. And I think in a way, this is what happens in this kind of debate about psychiatry. Is it part of medicine or not? Is it concepts similar to those of general medical concepts? So essentially, why and how do we compare psychiatry and general medicine? What is the diagnosis? How is classification used? How do we diagnose patients? What is the role of diagnosis? What is the nature of these conditions that we label with the diagnosis? And a little bit on how psychiatric and general medical treatments compare, and then some conclusions. Okay, so why compare psychiatry with general medicine? Medical doctors tend to, as I said, they're highly regarded in society, and for millennia we regarded as people of science. And of course, in the old sexist days, it was men of science, but now obviously over half of doctors are women. So because medical doctors have got a sort of high status in society, one of the central attack points by anti-psychiatry professionals, often psychologists, and critical psychiatry is to say that we're not proper doctors. We're not properly medically scientific doctors, or psychiatry is not scientific at all. And so one of the common phrases is unscientific diagnosis. But science, because it's not explanatory or names a cause, but science also includes being descriptive, not just describing causes. Obviously, the next step is to describe a cause, but you have to start with the description. Talk about invalid diagnosis with little utility. Talk about ineffective treatments, they're not cures, and that we use disease model prescribing. And of course, it's a bit like when you've got like the perfect brother and sister, and you're sort of uses a stick to beat you with. So general medicine is, regarded as the paradigm. And so how do we compare with the paradigm? Another reason for it's a good comparison is that they use a similar model to us and for similar purposes. Okay, so classification. Why do we have classification? There's several purposes. Clinically, it allows groups to be defined for research, which then you can then use that information for clinical purposes. to get information such as, for example, prognosis, what kind of treatments you use and what kind of response you'd expect, what kind of important correlates you'd expect to find with this diagnosis, and hopefully causes and an explanation. And one of the reasons for having a standardized classification is that you hopefully want to reduce the potential for abuse. So, for example, Stockish schizophrenia in the Soviet Union was a wild diagnosis, or an American family doctor who tried to introduce drapetomania for slaves that want to naturally enough run away. So the idea is that although you can't stop people in local areas behaving abominably, you can, by the fact that they're not using the standardized classification system, hopefully highlight that fact. So diagnosis has got a bridging function. And I divided it in sort of clinical knowledge and medical knowledge. And I suppose you could think about maybe clinical knowledge as procedural and medical knowledge as sort of more semantic. Not quite though. So clinical knowledge is things like how to assess a patient, take a history, examine the patient, what tests to run, but also involves things like ethical behaviour and the right professional standards and behaviour. Whereas medical knowledge is sort of things like what is the normal function of the human body, physiology, biochemistry, as well as illness or disease-related concepts, such as which we subdivided these diagnostic categories with this type of information that I described earlier. Including, I mentioned, so you mentioned above, we'll go into it later, what kind of knowledge is associated with diagnosis. So you've got your medical knowledge in terms of health, I mentioned physiology, biochemistry, etc. Your medical knowledge about illness and disease related to that. Your clinical knowledge on how to examine a patient. And then you've got condition-specific information. And there's 10,000 medical conditions, I think someone said. And we're not expected to know them all, but we're supposed to know the common ones, several thousand. And in our own specialty, they're increasing the rate of ones depending on what our specialty is. So there's a whole range of problems humans can have, and we subdivide them. So the principle of classification in medicine is that, this is from Kendall, so he said that what patients share with all other patients, what patients share with some other patients, what is unique to this patient, and I would add, what the patient shares with everybody else, because not everybody in the human race is a patient, are they? So if you concentrate solely what they share with all of the patients, you basically often do the same thing for everyone. If you concentrate solely on what's unique to this patient, you can't extrapolate from that patient to other patients. So basically, most research is based on what they show, what some patients share with some other patients. But of course, if all you do is focus on that, you lose relevant individual information of the patient. So the art of medicine is about taking what's like nomothetic information based on similarities with other patients in the research and what's unique about the patient. It must make therapeutic efforts in all these different areas. Okay, so what's a diagnosis? People say things like there's no such thing as schizophrenia, and they're correct. Schizophrenia is not a thing. Each diagnosis is an abstract concept that we use to summarize lots of complicated information based on similarities between patients with sort of purportedly similar sort of problem. It's not a thing, it's always provisional. There's no diagnosis set in stone. It should always be revised if the information goes against it. And the important thing to know is that you may classify their problems with a diagnostic label, but the person himself is not the diagnosis. And of course, as we know, diagnosis can have negative effects in people's lives. And one other common thing is we have a disease-based model. It's not true. We have a pattern recognition-based model in medicine. So why do we use categorical diagnosis? As we'll see later, many problems we see are dimensional. So why do we categorize, bunch it into categories? So the reason is form and function, isn't it? So we see patients like in the middle of the night, or seeing lots of patients, lots of appointments, or if you're tired, or being told you go to A&E, there's 6 patients waiting to be seen. Some of my colleagues have caseloads of 500. So it's a lot of stressors. And in that, so you often have to make decisions that are often categorical in nature, admit, not admit, what treatment to start or change. So categories is a sort of robust system that's easy for most people's minds to think. We think in boxes rather than sort of sludgy sort of dimensions. It takes less thinking. You're spending less time processing that and more time on taking into account multiple factors with decisions. And Parnas would say that we tend to have prototypic or ideal forms. So we recognize sort of the ideal for sort of a central aspect of a prototype more quickly the closer it is to the sort of central prototype. So the idea being is that you're more easily to recognize a starling as a bird than an ostrich, for instance. So the process of diagnosis is one of prototype matching. It's like a codon anti-codon diagram, isn't it? So you use your clinical knowledge in order to assess the patient, including observation, interview, relevant examination. And that interacts with your medical knowledge as to what you think you should be looking for. And then you match it to the closest clinical picture that's attached to a particular diagnosis. And then that leads you to a sort of management plan. And the diagnosis itself is like a quantum hyperlinked information seed. So in that diagnosis attached lots of sort of hyperlinked information, like what else it could be. So when you're seeing chest pain, and you see someone MRI, you're thinking, well, what else could it be? Could it be a PE? Could it be esophageal-gastric reflux, for instance, or even pneumonia or something like that. How it might present. We'll talk about that later. Maybe myocardial infarction. The typical clinical picture we talk myocardial infarction is basically Western male, isn't it? We're not really taught how South Asians present or women present, but we should be aware of how they present differently so we can recognize it. What else may be around? Birds of a feather flock together. So if one diagnosis is present, what other kind of problems are likely to be present? What are the likely complications? You know, someone's had a heart attack, what's going to kill them in the first 24 hours, an arrhythmia or hypovolemic shock? What are the likely range of outcomes patients like to have? And as I said, what kind of treatments and interventions they're going to do, what kind of range of responses they're going to get. There's also other type of information, epidemiological information, about how common things are. So we're going to look at common criticisms of psychiatric diagnosis. Now, it's not scientific, it's heterogeneous constructs. It's not clear-cut syndromes or diseases. There's no clear demarcations with healthy states. There's high rates of co-occurrence or comorbidity, and they're not etiological descriptions. So number one, Samei says that diagnosis are not facts of science. I don't know what a fact of science is, but that's the phrase he uses. At the bottom he says, all diagnosis should name a cause. Okay. So in fact, it's a bit more complicated than that. So there's basically you've got a basis of classification, you know, what some patients share with some other patients. And it's one of 1 to 3 of these, basically 3 broad categories. So at the top, you've got the simplest type, which is a clinical picture. So signs, symptoms, course, lab tests, and it tends to be quite descriptive. So I'll put on the left psych equivalents on the right, general medical equivalents. You see some of the commonest general medical diagnoses and functional medical diagnoses, which are quite common, are listed. And then the next thing, you've got changes in structure and/or processes, and you've got more of an explanation then on the left. You've got some psychiatric diagnosis. In fact, you get some people claiming Alzheimer's disease is not a psychiatric disorder. That's really strange because I'm sure my older adult consultants spend a lot of time looking after patients with dementia of Alzheimer's disease. I don't know, maybe. Anyway, altered dexamethasone suppression test and melancholia. And on the right side, got things like type 1 diabetes, MS, Parkinson's disease. And the final one is the cause of changes in structural processes. And this is more an etiological diagnosis. So obviously in psychiatry, it's like you can see someone's got hypothyroid-induced depression. It's got a brain tumour causing psychosis. On the right side, you've got things like TB, infections, injuries. Now, the trifecta is if you have all three being described. So, for example, TB. But sometimes you have 1 and 3. So, for example, you might have a brain tumour causing psychosis. So, you've got a particular etiological thing, you know how it happens, and a descriptive clinical picture, but you're not quite sure how the two makes the bit in the middle. Okay, so 1 to 3 of these. And obviously the ones at the top, the descriptive ones, are more sort of clinical pictures, and the ones at the bottom are more kind of scientific, really, and they're also more useful. If you can identify a mechanism or cause, you can think about ways to target it. And hope potentially get better treatments, or if you can identify cause, you might be able to do prevention, like a vaccine, that's topical at the moment. The descriptive ones, I'm going to use a food metaphor, because doctors like food metaphors, apparently. So it's a bit like a doner kebab, in the sense that it might have a function, you're not quite sure what's in it. You know, there's a whole variety of problems are included in that. So, kind of nature of diagnosis, what the nature of conditions. One of them is a broad clinical problem. We're all told these things, like the unconscious patient, off their feet patient, someone presents with low mood, chest pain. And we're described that we're kind of told lists, aren't we? Taught lists of what to look for, what to do. And then if you identify a more homogeneous group of problems, then we operate the rules for those homogeneous problems. So I've listed a few there. Okay, so obviously from everything from acute abdomen to feeling suicidal. So the next thing is the classic diseases and syndromes. Okay, so syndrome means to run together, and that's from syndrome, the English Hippocrates. I don't think he came up with, we called them species, didn't he? And the idea with that is that you would find clear-cut syndromes that differentiated the condition from other conditions from health. And the implication was that if you then identify the syndrome, it would then be linked to a particular cause. Okay, and the problem with that is that syndromes are multiply determined. What was it? Yeah, multiply determined. That means I think that multiple causes and syndromes. And I think disease processes are multiply. Is it represented? I can't remember. They're multiply expressed. They can present in different ways. So, for example, TB. Classically, or syphilis can present in different ways, great imitators. So this is what most people think medical conditions are like, and obviously some of the big ones are there. Arguably, people argue melancholia is a clear-cut syndrome. There's still arguments about that. All those things like type 1 diabetes, would regard maybe Alzheimer's disease as a clear-cut syndrome, of course, disease, but of course, we'll discuss this, it's a bit more complicated than that. DTs, etc. Okay. So the next one, so as I mentioned before, the idea was you decide a unique clinical syndrome, you discover it, and that would lead to research in unique disease process. Okay, and a reverse of the actual unique disease process causing unique clinical syndrome. Okay, now the next one is spectrums with health, and actually this is quite common. And so basically you have a spectrum, and at some point, I put illness there, but you could equally put disorder. I've not gone into disease. Between disease, whatever. I might do it later on. Anyway, so you've got this spectrum, and at some point you've drawn a line, and everyone above the line has got the condition, everyone below the line doesn't. It may be the other way around. Okay, so one side of the line is health, other side of the line got the condition. And it should be informed based on some sort of criteria, such as the risk of an adverse event, etc. So these are quite common. So obviously there's the metabolic syndrome conditions. Things like acne, but probably most examples of common mental disorders. Yeah, most examples of common mental disorders are like this. Now, there's also the theory that psychotic-like experiences overlap psychotic symptoms as well. And if you look at, obviously, the 5-factor model of personality, it's like that. And the diagnostic features of what they call the personality disorder categories like this as well. Okay. So now I've got what I call spectrums of condition. This becomes a bit more complicated in that it's a giant spectrum and then it's subdivided. And there may be a clear-cut separation from health, and there may not. It's Gordon Barclay. I used to have a Gordon Barclay at my year at uni, I think. One of it's him. Anyway, so These are also common. So when I was a lad at medical school, they used to just talk to us about bronchitis and emphysema. And then eventually they gave up, just said it's chronic obstructive airways disease. Another idea is obviously pink puffers and blue bloaters, and of course someone could be both. But the reason they're teaching these two different sorts, seemingly archetypes, is that give you important lessons about how in some people, if you increase the oxygen supply, you may actually be causing a problem. And some people regard TB as sort of one giant condition which is subdivided, but particularly things some people even try to argue diabetes is like this. Acute coronary syndrome is a bit like that. There are sort of informed, semi-informed divisions between from unstable angina, not NSTEMIs, to a full-blown STMI. Inflammatory bowel diseases, connective tissue diseases, and of course dementias start to get to be a bit like this as well. And some people argue psychosis is like that. So in the rainbow, bipolar is blue, schizophrenia is red, and schizoaffective is orange, yellow, and there's some sort of merging in between. And that's true if you look at sort of straightforward psychotic symptoms, simplistic description of psychotic symptoms. It's not true if you look a bit deeper, but yeah. So another thing is dementias as well also exist like this in the spectrums with each other. And we drew sort of so for example, Parkinson's disease with dementia and Lewy body dementia. And now we've got spectrums of conditions, and these are where there's underlying processes and networks creating multiple aspects. And then you name the different aspects. Different aspects are given different names and treat as different conditions. And in our head, we think of them as different conditions, but really they're just different aspects of the whole. And we could think about religious metaphors like the Holy Trinity, for instance, or various deities, or 99 names of God or something in Islam or that. So what it is that, so if you look at the obvious example, metabolic syndrome. So metabolic syndrome, they used to call it syndrome X. So they've got all these common processes leading to different aspects. And you name the different aspects because there might be, for example, different tests, like different measurements. Some of the treatments will be common because of the common underlying processes. So metabolic syndrome is don't do what I do, is do regular exercise, eat well, that kind of thing. Don't be like a Glaswegian. And some of them are specific, and some of the complications are specific. So diabetic retinopathy is different from hypertensive retinopathy. Other examples: autoimmune inflammatory disorders, myeloproliferative disorders. You can switch between them. And prototypic the personality disorder categories. In fact, the high rates of co-occurrence, some of the metabolic syndrome, and obviously internalizing disorders and externalizing disorders, and the dementias themselves. So this is sort of interaction, isn't it, between vascular disease and Alzheimer's, and there's interaction between Lewy body disease and Alzheimer's as well. Okay, so now we come to injuries. Injuries are not, that's something quite different. That's something external to the organism that causes some sort of problem to the organism. And some people might say the mental health components may be acute or chronic trauma. And then we've come to the next, so I just keep checking my watch to make sure I'm not overrunning. The next one's the nature of the diagnosis. And these are quite a big group and they're quite disparate. So it said that health professionals or health and social care professionals might be some benefit. So the obvious example is, one obvious example is pregnancy. Pregnancy is not a disease, it's not an illness, it's completely normal. And childbirth. So why are doctors and midwives involved? Well, the reason is that, one reason is A, we know that if people have regular antenatal care, you improve the outcomes. B, pregnancy and childbirth can cause medical problems. So gestational diabetes, pregnancy-induced hypertension, placenta previa, postpartum hemorrhage. There may be some sort of psychosocial stress where someone may benefit from support, maybe bereavement. Doesn't necessarily be a psychiatrist, might just need some grief counselling or something like that. And there's also some situation where healthcare professionals thought to have useful skills. So one example is termination of pregnancy, where there's no fetal abnormality and there's no threat to the women's, well, no great threat to the women's health. Obviously, mortality is always increased by pregnancy. But the reason obstetricians, gynecologists, did a year of that is involved because they always look, if we don't get involved, then somebody else will. and it'll be dangerous. Women will either die, become infertile, or suffer morbidity. Another example is cosmetic surgery. So the cosmetic surgeon is a skilled and has got access to the equipment, clean operating theatre, to make sure the job's done well. And then I've talked about problems or difficulties for help is sought from a health allied professional, and they might need a diagnostic label in order to get help. So, for example, a child with some sort of behavioural difficulties, which is usually not due to disease or an illness, but some reactions to difficult circumstances. Okay. All right. So the next one is reliability of medical and psychiatric medical. I'm going to shrink my bit here so I can just concentrate on the slide. So many common psychiatric diagnostic constructs are in the moderate to substantial range, kappa ranges, in the DSM-3 to 5 and ICD-10 field trials, in fact, even ICD-11 field trials. So that's a cap of 0.4 to 0.8. And remember, that's not an objectively decided range. That's a range decided on by experts. So that's their opinion. Now, MGD was shocking. If you remember, the DSM-5 was 0.2 something, wasn't it? It was terrible. But another study, they used actually standardized interviews, and they got up to 0.72. So it might have been how they carried out the trial. Of course, the trial itself, the DSM field trial, might be more representative of clinical practice. Now, if you look at physicians aren't so interested in actual interrated reliability because they feel they've got kind of like a gold standard often, although they don't functional medical constructs. But for example, disease joints in a 0.348 kappa. Trying to decide some of the MI or cardiac schema based on the ECG and troponin results, 0.41 kappa. And then there was a paper, I think it's in the Lancet, isn't it? BMJ. And so what they did was they had respiratory physicians who were doing their exam, practicing for the exam, and they went and saw these bunch of respiratory patients. And then the gold standard was what the consultants said they had based on their own examination and access to the results. And so they found that 0% diagnosed bronchiectasis, a third diagnosed pneumonia, but 100% for asthma and pneumonectomy. But the average was about 72%. So what I'm saying is actually the reliability is similar between general medicine and psychiatry, although general medicine's advantage is that for all the conditions, they've got tests that they can appeal to, in a sense, to help make the decision on the diagnosis. So heterogeneity, and I've compared these diagnoses like Donna Kebab's. So many psychiatric diagnostics constructs are heterogeneous, and diagnostic criteria use indexical rather than constitutive. So for example, the depression criteria is how we recognize depression, but it's not the whole of depression. So if you look at the depression criteria, there's very little there to say, for example, pain. But pain is one of the commonest symptoms of depression, isn't there? There's very little there talking about the subjective feeling of passage of time or other important experiential aspects of depression as well. But many general medical diagnostic constructs are also heterogeneous, including, and they also use what we do in psychiatry, polythetic criteria. So polythetic is that no one criteria is sufficient to make the diagnosis, usually a mixture. So examples of medicine include infective endocarditis, myocardial infarction, rheumatic fever, and autoimmune conditions such as MS and SLE. And part of the reason for this is the idea is that we in classification talk about carving nature of the joints. And here's another food metaphor, is that nature isn't a giant multi-limbed turkey. Nature is messy and complex, but we've only got human brains, and we subdivide it into categories to make it easier for us to manage this messiness. So how useful is it? You know, this is what someone puts it, this is when the theoretical tire hits the rubber of the theory hits the road of clinical practice. And the utility of diagnostic constructs is often underestimated because it's more of an evaluation, isn't it? It's a bit like how Scottish you feel compared to how British you feel. There's no sort of, it's a value-related judgment. And for example, bipolar versus unipolar depression. Well, I know that I've got bipolar depression, I just don't give antidepressants on their own. And lamotrigine is said to be more useful in bipolar depression. Bipolar versus schizophrenia, well, we know schizophrenia is significantly worse prognosis. They're more likely to have cognitive impairment. Phenomenologically, they're more likely to have disorders of self. I know that lithium is more useful for core symptoms of bipolar and schizophrenia than they are for the core symptoms of schizophrenia. And in fact, if they've got psychosis and bipolar, I know that lithium will be helpful. Whereas if they've got psychosis and schizophrenia, lithium won't be helpful. Many general medical constructs also don't just rely on the diagnosis. So if you've got CURB-65 and pneumonia, famous Glasgow Coma Scale, and whenever I hear American medical shows say that, I get a little surgery pride. And the DAS-28 in rheumatoid arthritis. Okay. So the fact is, what psychiatry is, why, psychiatry is social factors. Well, social factors are the biggest terms health, not just in psychiatry, but general medicine. So I went to medical school, we said the biggest medical problem in Glasgow is damp housing. TB has always been regarded as both a social disease and an infectious disease. It was regarded as social disease first. It's both. So rates of TB shot up in the form, so when it broke apart, lack of access to healthcare, poverty, increased inequity, worsening housing. And childhood trauma has affected both, but it's got more direct effect on mental health. And the effects of physical health are usually more indirect. So, for example, risky health choices such as smoking, illegal drug use, higher alcohol use. Well, I think someone's written a book called The Body Keeps Score. I've not read it yet. I don't know whether that makes a different case. I don't think I've not mentioned this slide, but I suppose one sort of difference is that if you decide something is a suitable condition for medical health care, involves values, but the values are more likely to be shared for general medical conditions than they are for behavioural conditions, particularly if they involve things like addiction, regards addiction. Well, most people pretty agree that schizophrenia across different populations, doctors, nurses, politicians, is an illness or a suitable condition for medical treatment. But I think even when the shared values are shared, they're still more obvious in psychiatry compared to medicine. Anyway, this is one talking about disease-centered prescribing, disease-centered prescribing work in psychiatry. This is one of Joanna Moncrief's hobby horses. I'm sorry, this slide's quite small, so I'll try and summarize it for you. And she still claims that this is true. As far as I think she wrote something recently that said it's true, but she's seen this data, so she knows it's unlikely to be true. So she just assumes it based on her reading of Stahl or something like that. So I actually asked my colleagues, and essentially I asked them about different scenarios and whether they used a disease-centered model of prescribing or whether they used what is said like a drug-centered model, that is, drugs have got unpleasant effects, but they might be useful, or an outcome-centered model, which was essentially it's like there's empirical evidence that this drug is effective in this situation, but we might not be sure how it works. And in fact, generally for almost all conditions such as antidepressants and depression, even stimulants in ADHD, although I would probably have a more drug-centered approach then, benzos and anxiety, lithium, bipolar, antipsychotics in psychosis, they generally have an outcome-centered approach. That is, they don't think they're reversing disease, as a disease-centered approach would suggest. What they think is it's effective, but we're not quite sure how. The only exception was thiamine to prevent Wernicke cross in which most doctors then had a disease-centered prescribing. So, well, that suggests is Moncrief is wrong. But, being wrong has never stopped critical psychiatrists from repeating their sort of hobby horses. This is an utterly busy slide, I'm very sorry. Essentially, what it says is the effect sizes and number needed to treat. And essentially, there's some medical treatments that are probably much more effective than psychiatric treatments. So a PPI in reflux esophagitis number needed to treat 2, effect size 1.37. L-dopa Parkinson's disease 0.93. Similar though to the effect size of ECT depression, which is 0.908. This is almost a big effect size versus antidepressants. So it's ironic those people want us to stop ECT on the basis they don't think it's effective, but we would stop everything else, including psychotherapy. Or indeed, people want to stop using antidepressants and antidepressants when they have an effect size of 0.3, 0.4. So if they think, interesting, it's same effect size versus psychotherapy versus placebo. So if we're going to stop antidepressants because they're ineffective, we stop psychotherapy. In fact, the only thing we give really is ECT. Antipsychotics, got a relapse prevention rate of human-age treated 3. That's very good. Some medical treatments aren't that great. COPD steroids, 0.2 to 0.36, for instance. Other ones are similar range antidepressants. And the idea that we don't cure conditions, well, a lot of medical treatments don't cure conditions, and sometimes they even have an unknown mechanism of action. So thiazide diuretics, for instance, in the hypertension, we don't know how they work. I read a pharmacology book, claimed to know how it worked, but in fact, it's not how they work. But we know that actually, among several antihypertensive agents, they're amongst the most effective for preventing adverse events. Some we know how they work. Like I said, obviously, like oral antibiotics, oral antihypertensives, although they don't necessarily reverse disease. So what is disease in hypertension? We're not quite sure, but we know the physiology enough to have agents that can reduce the blood pressure. So I think we're in the home straight now. I think I've kept to time. So one theory is mental illness is not defined, hence no point using diagnostic constructs. You've got to define mental illness first before you can then proceed, which makes a sort of logical sense from the point of view of the lotus eater. But from the point of view of the practical clinician, it doesn't make any sort of sense. Concepts of disease and illness in general medicine are not defined either. They're still debating it. They will always involve values, same as psychiatry, but values more like to be not as universally shared in mental health. But the point is that when people come in, you don't sit there and say, well, since the concept of illness has not been decided in general medicine, I'm not going to do anything. This person's in pain, and you do an ECG and they've got an MI, and you say, well, let's treat the MI. You don't say, sit back and say, well, no, we're going to wait until disease is defined. Psychiatry is the most complex medical specialty because we deal with the most complex thing we know about the universe, which is the mind-brain. And it has no objective measurements of mental content really I'm aware of. The closest we've come, I think, is that if you're making someone watch a film and you wire them up to some magnetic encephalograph or something like that, you can tell what scene of the film they're watching. And in fact, I think you might even tell what the response to that scene of the film is. But that's if you control to a large extent what the input is. So that's the best we can get at the moment. Values will always use to define what thoughts, behaviours, and experiences are illness or disorder. Even if you develop objective measurements, you still have to decide what we regard as disvalued. So, for example, even if you could objectively measure mood in some sort of state, we still have to say what mood states we regard as disvalued and require treatment. In general medicine, there's greater value agreement about states being illness disorder, as there's a greater ability to have objective measurements of them. So in general medicine, for example, they say 70% of decisions are made using results of lab tests, whereas in psychiatry, obviously, we're still based in sort of clinical judgments. But functional disorders are common in medicine, and the labs test are just used to exclude other conditions rather than the disorder, functional condition directly. And stigma exists for several general medical conditions such as epilepsy, HIV infection, etc. Now, the prospects for improved treatment are great in general medicine because for many medical conditions, general medical conditions, we have a greater understanding of the mechanisms involved and how to manipulate them. Psychiatry is often depicted as uniquely influenced by big pharma, but I've said that recent American research where they have a proper Sunshine Act and they everyone's got to declare their payments to industries. Psychiatry is well down the list. Usually things like cardiovascular medicine, surgery, etc., are well up the list for being influenced by industry. Part of it, though, is because we've not had any recent big drugs. It might have been a bit different in the early 80s, and early 90s when we were having SSRIs and atypical antipsychotics. The other thing is classified problems, not the person, but personality disorder diagnosis is the most problematic in many respects because you're effectively classifying the person there, aren't you? And hopefully you've seen that some of the criticisms of psychiatry sort of would also apply to general medicine. So if you want to throw psychiatry out, you can throw general medicine. You can get back to giving people leeches and exorcisms and all that kind of stuff. So one of the reasons that criticism persists is because people just aren't aware of general medicine, what it's like. So if you watch TV shows, they're like gods, aren't they? It's all high tech, and it's all dead easy. And, you know, find the right result. You've got a house, they all sit around a table and decide what the diagnosis is. But that's not what medicine is like. And I think in my case, many years I've done general medicine, but I've got enough memory of it. And for this book, I actually read the enemy textbook Davidson's again, just to refresh my memory. But the interesting thing is, why do critical psychiatrists not remember it? Now, one example is, the diagnosis assumes mental health problems as neat categories. But if you look at the introductions, for example, DSM, they say they know it's not the case. The things are dimensions, they're just represented in it for convenience. The diagnosis assumes a biological causation. But again, DSM and ICD-10 clearly state that's not the case. People say biomedical, but if you actually look at the curriculum, for decades it's been biopsychosocial. In fact, someone accused me of gaslighting him because I said, well, your observations, maybe it's biomedical, but in fact, if you actually look, your observations may be biased or inaccurate. If you actually look at the curriculum, it's biopsychosocial. That's gaslighting, for instance. I don't think he knows what gaslighting means. He doesn't know what biomedical means. He doesn't know what gaslighting means. So some of the reasons could be social. It might be a guild warfare. It might be psychological. It's you sort of create a straw man sort of thing for you to beat up, and you don't want to give up your straw man. It's too nice to have something to attack. And I suppose Plaxton was saying something with the EU at the moment with the vaccines. So the UK is the big bad, isn't it? And we are keeping their vaccines. It's a simple case they were just unlucky, weren't they? Their vaccine. Unfortunately, the production centre hasn't worked. Anyway, I think that's my bit now. I think I've finished now. If anyone has any questions they want to ask me.
Dr. Huda, thank you so much for a really interesting talk. I think we'll I've certainly got questions myself, but I think we should open it up to the audience. So if people want to indicate they have a question, perhaps by just sort of writing, just kind of indicating in the chat box, and then we can ask you to kind of ask your question in person.
I don't buy it.
Whilst,
I can't buy it anyway because I'm on the screen.
Whilst I suppose, whilst I'm giving people a chance to think, I suppose my question was, I mean, a main theme of the book, and something that was incredibly valuable to me was the emphasis that a lot of the criticisms or controversies or issues, whatever you want to call them, within psychiatry aren't unique to psychiatry, and it's actually, you know, a lot of the criticisms will extend across the whole of medicine, and a classic example would be the idea that the role of values, for example. So I suppose with that in mind, is there anything that you, and I suppose one thing we can take from that is that, okay, if you're going to criticize psychiatry, you're also criticizing general medicine. And I suppose with that in mind, is there anything that you would like to see both psychiatry and general medicine do differently? Because although some of these criticisms may be not unique to psychiatry, we might argue that they're still valid across the whole of medicine.
I mean, obviously, one of the obvious things is we're a bit top down, aren't we? Now, medicine and psychiatry, they're both top down, doctors decide. Whereas, in fact, so if you look at Sackett's book, isn't it, Evidence-Based Medicine, the idea is the doctor is the doctor and the patient are a team, and the patient brings out what they want, we bring the sort of knowledge, and then we make a joint decision. But it's not really like that, is it? Obviously, in psychiatry, we're more likely to use compulsion. That's something I didn't cover there. But yeah, we're more likely to use compulsion than, although general medics use a lot of compulsion, don't they? They have a quarter of general medical surgical patients have delirium and therefore lack capacity. But we're more likely to use force or use things against expressed consent. But I think that what we think of as important isn't necessarily what patients think of as important. And one of the interesting things is that has led to big gaps in knowledge. So although, for example, the diagnostic criteria of schizophrenia may be heterogeneous, there's clinical research we could have carried out over the past few years that we haven't carried out. So, for example, obviously there's 1 or 2 trials that looks at stopping medication after the first episode. That's interesting. And we know that actually most people still relapse anyway. That seems to improve outcome based on 1 or 2 studies. But we haven't, for example, looked at people after 5 years. So people who are still on antipsychotics after 5 years, if you stop medication, what happens then? You know, these kind of, we know that by 8 to 10 years, 30% of people with schizophrenia have recovered. So we don't have, and appreciate it's hard to carry out long-term research. But if we carried it out, we've had these criteria essentially for 20 years. We could, 30 years, DSM, I suppose, 3 came out in 1980, I think. So that's 40. That's 40 years, got to show you how old I am. So we had time to carry out these studies, but we've not done it because to us that didn't seem that important. We just stuck people on psychotics. Instead of thinking, well, a lot of patients say, well, I want to know how I'm going to come off it. Well, that's an example of how, from our point of view, the top down, we've not taken into account what's important to patients. And Rachel Cooper, she said, like, when we do diagnostic criteria, we can advance medicine. At one point, I agree with Sammy Timmie, is that we can show an example to the rest of medicine. Rachel Cooper's idea, so diagnostic criteria, instead of just having experts, why can't we have patients and the relatives in and sit down and say, right, when we make a decision about how to define a diagnosis, what's important to them as well, not just what's important to the experts, because I don't know if you read about if you read the one with the personality disorder description about it, it just ended up being a bun fight between the researchers and the clinicians, and the clinicians won because yeah, I mean, it would be nice to see what the patients thought about it. I think most patients want to get rid of personality disorder diagnostic categories. Don't find them helpful. Yeah, so there's things we can do that would make it better, like stop being in charge so much. Another thing is, I suppose, part of the reason for the bun fight with the psychologists is the sort of the history, and I think it's more in Britain. So it seems more in Britain than the rest of the world. Britain leads the way in conflict. Is that we kind of suppress the psychologists. And it was only the Trevelyan report in the early 70s from a psychiatry professor who said, oh, would you not believe that the people who are trained in psychological science, they can do psychotherapy. They don't need doctors, medical doctors to be in charge. They can do it themselves independently. So because you've got that long history of sort of suppressing them, the sort of consequence of this is sort of a kind of like anti-medical kind of attitude amongst sort of leading clinical psychologists and academics and their profession. So yeah, I think what we have to learn about is to sort of, now there's a good reason why doctors were quite standoffish and in a pedestal, because that's the only thing we had. We are God, you will get better. If you don't get better, it's your fault. So that kind of enhanced placebo effect from being in charge and being prestigious. But we don't need that so much now. Hopefully we've got more evidence-based treatment so we can try and induce a placebo effect through a different way, through being collaborative.
Thank you very much. We'll just move to Peter Benny. Peter, do you want to unmute yourself and ask your question?
Yep, I'll give it a go. You may have seen in the chat bar that my video probably isn't working, but I think my mic is. Just by way of background, I'm a relatively recently retired general adult psychiatrist, and part of my interest in your talk is that I did work in my early training in 1990 with a Glasgow consultant psychiatrist who was absolutely and undoubtedly working with the bio model, and that was it. And even now, if faced with any particularly clinical issue, I do find myself thinking, well, what would he do? And then I do the opposite. I also think
biomedical then?
He was just, it was medicines for everything. Well, it was ECT for everything actually, but then medicines for everything after that, and almost to a robotic script. Anyway, that has certainly influenced my practice throughout my career in the opposite direction. I also think you're absolutely right about the parallels with general medicine, and just as I had I feel like an anti-mentor early in my medical training, I would often find myself thinking back to the ways in which an extremely good general physician that I trained with would practice medicine, and that was very helpful to me in how to practice psychiatry. My question's about a specific thing that you said, or at least I think you said it. It all went by very quickly, but towards the start of the presentation, I think you were saying something along the lines of we can criticize diagnostic systems for being overly simplistic, but often that is driven by the need for that in medicine, because as doctors, particularly as presumably as junior psychiatrists, we find ourselves having to make quick decisions at 3 o'clock in the morning. Do you want to expand on that a wee bit, try and justify that?
So what I'm trying to say is, look, a classification system depends on what the user wants from it or needs from it. So the diagnostic classification system won't suit everyone's way of working. One of the issues is, I think, in terms of guilds, is that obviously DSM, say in America, is quite dominant, isn't it? So people feel like it's, like I said, it's like they're being colonized by external power. So if your way of working is a different way of working, then a diagnostic system might not be useful to the way you work. If you've got time to see lots, a few patients regularly, see them week after week, after 2 after weeks, and you'd probably not need a diagnostic formula. You'd probably favour more, the diagnosis should be as part of a formulation, shouldn't it? The diagnosis is the start of your management of the patient. That's part of like what they share with some other patients, and then you formulate on top of the diagnosis as well. So you keep some of the information from the diagnosis. We also do the information from the formulation, which is more specific to the patient. And if you are working a different way, where you're seeing relatively small numbers of patients in office hours, for instance, and the same patients week after week after week, then your need for that diagnostic information is probably not going to be great. You're probably just going to stick really to the formulation. You might need a diagnosis for certain administrative purposes. I didn't go into the other purposes of diagnosis, like administrative purposes or whatever. So yeah, so you use the classification system that's most useful to you in the way that you work. I only have 50 minutes to see my patients. It's quite exhausting. So I end up sticking to diagnosis plus formulation. So yeah, so if you work in a different way, different ways of working, you might not need a diagnostic classification. And I think part of that, I said, the conflict arises that people have to use it and they feel annoyed about having to use it, wherein it might not be very useful to the way they work.
Okay, thank you.
Thanks very much. Mark, do you want to ask your question?
He's gone shy.
Hi there. Yeah.
Hi, Mark.
Hiya. I mean, I don't disagree with the idea of the kind of your kind of criticism of a kind of infight or fighting between different guilds. I suppose it's just something of a kind of medicine's not a neutral force in that, as you've acknowledged, but I suppose it's just a kind of thought about why kind of I suppose in the comment I made, it was in reference to the pandemic, and actually countries which are doing better seem to be not less driven by kind of thinking about individual medicine and thinking about people in isolation, but more terms of people within communities. And I wonder about that in terms of how we think about mental health. And I suppose just a kind of sense of, in sort of taking the angle that you're taking, I wonder if we just go further down the road of a kind of an individual kind of notion of understanding how health in general, but also mental health in particular, is conceptualized.
So yeah, so public health was very important in my curriculum, wasn't it? So they always thought that the public health physicians had an impact on greater numbers of people than the individual clinician, didn't they? We just didn't see it because they didn't see the patients and we would get the benefits of it as individual clinicians. but they wouldn't see it. So it's the importance is, so I said in my book, so all these poorly paid navvies that were paid to build sewage systems to provide clean water, they saved more lives than the highly paid doctors of their era, didn't they? So I think public health will always do better than an individual clinician. You can. The thing is, you've got to just try and improve society as much as possible to reduce the number of mental health problems. Even in a perfect society, you still have people with health problems who need individual treatments, but you'll have less. The problem is that we have at the moment, as Winston Churchill said, democracy is the worst system except for all the rest, isn't it? So people willingly seem to vote for a party that will make their lives worse if the policies are carried out or our policies are being carried out. Whereas what we know would make society better and less harmful to people, society doesn't seem to want to enact so much. We were better probably at enacting change in the 19th century and early 20th century after the war, the World War II, than we are now. So yeah, so we should be, in terms of a public health approach, including mental health, but general health as well, but looking at making changes at the macro level and the societal level rather than the individual level. In terms of COVID virus, I think it does help, isn't it, if you don't have a bunch of incompetence in charge. I think the people who've done best, I think, have been the Northern Irish and the Welsh, although they're the least celebrated. They're kind of ignored, aren't they, in our political discourse, but those two countries, the UK, have done the best. So yeah, the fish rots at the top, doesn't it? So yeah, I agree with you, yeah. So if you really want to reduce the amount of people with depression in the community, you don't start at one end, which is trying to treat as many people as possible, but you start at the other end, which is trying to reduce the conditions that produce depression as much as possible. Does that make sense?
Yeah, it makes sense. It's just a question of almost like why bang the drum for a medical model then? Well,
I'm not banging the drum. Well, the thing is, there's always going to be individual clinicians doing, when people come into clinic, you still got to help them, haven't you? What's the way that I'm trained to help people is the medical model. And there's people who, for whatever reason, want to downplay or attack instead of working together. I don't think other medical specialties have as much. Maybe obstetricians sometimes have conflicts with midwives, but yeah, so it's just the medical model is one way, but it's completely compatible with a public health model as well. They're not. If you think of the big condition thing like metabolic syndrome, there's a lot of commonalities, isn't there? Just different aspects. The public health approach helps more people, but you still, they don't see it directly, but they know it, and we know it. And it doesn't mean it's not compatible with an individual clinician model. It's more important than an individual clinician model.
I guess maybe my point relates to the kind of a bit of a battle that can go on. You're talking about with critical psychiatrists or with psychologists. And my sense generally of critical psychiatrists and psychologists generally, not all, is that they probably give more emphasis to a kind of public health type perspective.
I don't think so, not critical psychiatrists. I'm not sure critical psychologists do either. I think they present their own magic solutions. I think, but my experience of them is they have a magic solution that ignores the issues. I mean, if they had the public health, I think they would falsely portray there's a dichotomy between public health and individual health. There's just two different levels of operating, isn't it? So Strathty and Thornycroft, don't they? They did that sort of levels of intervention, don't they? So you've got the societal level, population level, service level, team level, individual level. I think the most useful critical psychiatrists are probably people like, was it Phil Thomas? And who's the Irish one? Bracken. And even when they can criticize the medical model, maybe in a funny kind of way, you don't have to listen to it, but they've got sort of interesting ideas, haven't they? Whereas someone like Moncrief and Timmerman, you know, they produce ideas, but the evidence behind them isn't great. PTMF, well, you know, where's the evidence? They've not even checked the inter-rater reliability. And part of the issue, I think, with those two branches is that any criticism, you're not allowed to criticize their ideas, because if you criticize their ideas, they get nasty in various ways. So, you know, I always think, if your ideas are so good, why do you have to act like that? Any other? Sorry, Mark. Have you got any more questions?
Yeah, I'll leave it and let other folk get a chance. Yep.
All right. Thanks, Mark.
Thank you very much. Ian, over to you.
Hi, Ian.
Hi there. How are you doing? Thanks for the
fine.
talk. Very good. And I've even bought your book. So
Oh, thanks, Ian.
enjoying that. I mean, I put a question in, and what I'm about to say is kind of linked to that idea. There's a little book, I forget the author, The Anatomy of an Epidemic. So it's
is it Whitaker?
Yeah, no, it's a public health emergency. And the emergency, and it's mainly the United States, is overprescription of psychiatric medications.
Mostly in primary care, but also here as well. I was talking to someone today, so I've interrupted, but someone today said their son went to, in 3 minutes, he got prescribed an antidepressant. And I'm thinking,
yeah.
Well,
So it's children getting powerful psychotropics and so on. I think my question was, to what extent is the pharmaceutical industry pushing our diagnostic expansion? I suppose oxycodone would be an example in a different field.
Yeah, I mean, I think the difficulty is that ideally, as a GP, I mean, I'm not sure what the situation is like in Scotland, because it's a different country, I suppose, in England. Although obviously that might get me into trouble. Right? Both a different and the same country. The issue is the GP has someone, let's say, a common mental disorder, but, you know, depression and anxiety overlap significantly, don't they? They're not separate things. And they refer them, say, to psychotherapy, but the wait's months, isn't it? Or a year or something like that. So if the patient is distressed and there's nothing immediate they can do, like maybe the patient needs some sort of application support to get new housing or something like that, the GP's left with someone who's distressed. And what are they going to offer them, isn't it? So yeah. I suppose the issue is that if it can be almost as quick to get access to psychotherapy as it is to a prescription, then you'll naturally see that more people get psychotherapy. The second thing is the rise of prescriptions. A lot of it is due to people being prescribed it for longer, as they're recommended to prevent relapse. That's recurrent depression. But I think, to take back to Mark's talk question, I mean, part of it is that you have to kind of hopefully address the societal drivers that produce depression and anxiety, as well as the GP and the front line having to prescribe it. The problem is that we're not carrying out policies to do it, neither in Scotland nor England. I don't know about Wales, but are carrying out policies to reduce these kind of macroeconomic social factors that cause depression. But they have spent billions now out.
Yeah.
In the UK, in England, the two things that mental health have got the biggest increase in spending was psychotherapy and forensic secure care. But demand is so big. I mean, maybe book therapy and computerized therapy might help, or more group therapy when COVID's over. That might help. But the issue is that the demand is high. GP's got what, 5-10 minutes?
Yeah. Yeah,
is anything else? Sorry, go on.
There are issues about whether we make people dependent and turn what might be an acute situation into a chronic situation.
Yeah.
It's one of the accusations against us, I suppose. But
I think, yeah, there's an issue is that obviously some people get persistent severe withdrawals. The Reed meta-analysis is terrible methodologically. And then if you point it out, you get these gales of hatred from him. But some people, so some agents like Proxtin and venlafaxine are obviously much more likely to cause severe persistent withdrawals. And then obviously it's important to distinguish them from a relapse of depression, isn't it? And there's an insufficient amount of services for people. But yeah, so even if something is rare, if you've got millions of people on antidepressants, then even a relatively rare occurrence will happen more than it should.
I mean, I think I've been around in psychiatry since what, 1984. I started working.
Gosh.
Well, one of the things that strikes me most is, you know, when I first started out, personality disorder was pejorative and excluded people from treatment. But I think now people seek, you know, a label like EUPD, and it actually gets them treatment rather than excludes them from treatment, which on balance I think is a step forward. But because these are distressed individuals, whatever we want to call it, so the bit that I think is kind of missing from what you presented is the patients wanting a diagnosis, the patients, and what having a diagnosis means to the patient. So it's not a one-way thing from doctor.
Yeah.
Right, I've heard your symptoms, this is your diagnosis. The patient is probably game playing. I don't mean in a...
No, I mean, yeah, I mean, I only mentioned like the clinical kind of utility functions of diagnosis. I didn't mention other things, like obviously, like someone once said, if you put a formulation in your application for a PIP form, you're not going to get it. You've got to give them what a diagnosis is. So yes, I think what someone is hoping for when they get a diagnosis sometimes sit and say, who are these people with similar problems to myself? This problem has been recognized in medicine as a problem. I've got a recognized problem. I can access information about it. There might even be a charity or other groups of people with a similar problem I can discuss it with. And they'll often get more helpful information from them than they will from a doctor. And maybe sometimes we get some sort of understanding, even if it's the sort of not what we would regard as an understanding. If it's something like, if this happens, I might tend to lose my temper. We can't explain why it happens, but they have a sort of...
Well, that's the other thing that changed the internet and access to information. Thank you. I'll stop there.
Thanks very much, Ian. I've got another question, but I just want to give anyone else a chance. Is there anybody else who wants to ask anything?
Could I ask something just very quickly? It's David here. Let me come off my... It's just about thinking about the medical model in psychiatry. Is it possible for the medical model to make sense of human agency? That's a big question, isn't it?
All right.
But it's an important one. But without just objectifying. And then the dilemma is when you objectify, you lose something.
Yeah, I mean, I suppose the medical model is only one way. I mean, it was one thing I've not added. The medical model is only one way of viewing a problem. It's not always the best way for a person. It's certainly not the only way. It may not be the only way. I suppose the problem with the medical model, because it depends. If you're describing it as descriptive, that descriptive level, then you're maybe not dealing with human agency. In the fact, you're not saying that this is what A decides B. So you're not saying it's a mechanism in a way, isn't it? You're not saying A decides B because neuron X fires and has value Y or something like that. You're just saying it as a description without necessarily saying why it happens. And that's probably the only way you can deal with human agency without objectifying it. Although by describing something, you do, in a sense, I would argue, objectifying something in a way, don't you? But should we be dealing with problems of agency? So some people regard some of the negative symptoms of schizophrenia as agency, don't we? And then obviously we do have issues of agency.
But then you're objectifying it, aren't you? And you know, when you sort of bracket off the person,
yeah,
and say, okay, we have to put the person to one side, but we will describe something else.
yeah.
Then it becomes problematic if you're trying, as psychiatry often does, to think holistically.
Yeah, and I think you got to understand the human model is it's a model. It's not the whole truth and nothing but the truth about something. It's just a way of looking at something.
Mm-hmm.
And as I said, other ways are available, and other ways may be more useful to that person. But I think it's fine because we're in that sort of normathetic world. It's going to end up objectifying, isn't it?
I don't know.
I suppose.
I mean, we're at the end of we're running out of time, aren't we?
I mean, you can try and create idiographic sort of information. So the World Psychiatric Association, doesn't it? It's got its suggested classification system with both normothetic elements like diagnosis as well as idiographic sort of elements. So the kind of based sort of without objectifying agency would probably be the sort of least sort of medically bits of it.
And I suppose there's a real, or certainly seems to be a resurgence of kind of phenomenology and going back to our roots of actually looking at the phenomenological experience of patients. And in my mind, I wouldn't see that as at odds with the medical model. You know, I would see that as something to be incorporated and to guide practice, I suppose.
So if you describe the psychopathology as dialogues of the suffering of the soul, so to speak, it's not necessarily the same thing as cell pathology. And of course, phenomenology, back to things in themselves. Yeah, I mean, that's in a sense, that's part of science, isn't it? Describing something. And people would argue that phenomenology is the perfect way to describe what people's experiences are. Of course, some of that in Jasper's kind of description was a bit like he made it analogous to pathologists describing features in a tissue slide, isn't it, or a cell slide. So in a sense, that's objectifying, isn't it? Yeah, I mean, I'll have to recommend, if anyone's interested in the phenomenology of schizophrenia, if you go to www.easenet.dk, Professor Parra has a lot of interesting stuff there. I went to the course in Copenhagen, it's great.
Well, thank you so much. I think that's probably us. Thank you so much for taking the time to speak with us, Dr. Huda. It was a really interesting talk.